I love working in substance use, and I love when people love it. But unfortunately, it's not a common experience. Oftentimes, clinicians who work in substance use feel frustrated. And oftentimes, that frustration stems from the limitations of working within an abstinence-only paradigm. Other clinicians feel like they have to refer clients out who reveal that they have a substance use issue because they don't know how to work with it, or it feels frightening to work with people struggling with addiction. This fear, this frustration, it's typical, it's commonplace, and it's completely normal. But also, we can work around it. Part of the problem for how we've gotten to this place is that mental health and substance use have been historically siloed, kept separate. So the idea of combining them feels really overwhelming. When you combine this with common ideas and stigmas around substance use, it leads clinicians to feel stuck, either stuck in their limitations or stuck in their fear. And when we operate from a space of fear or frustration, we're not able to meaningfully connect with our clients. My name is Kim May. I'm a licensed professional counselor and a licensed marriage and family therapist. Perhaps like many of you, I knew that I wanted to be a therapist. Just didn't know exactly what I wanted that to look like. And a colleague of mine was working at a methadone clinic. I didn't know a lot about it. And I was like, what's it like there? And he said, I love this. He said, it's like doing therapy on a pirate ship. And I was like, I don't know what that means, but I want to do that. And I want to do that immediately. I would come to find out very quickly what that meant. It ended up being my first job out of graduate school, and I loved it. I took to it immediately. It was a little chaotic. It was a little rough around the edges. That tended to be a good fit for me. Admittedly, I'm not the softest kind of therapist. But in this work, oftentimes it's not just who we're drawn to, but who is drawn to us. And I found a home in the methadone clinic. And I found my North Star in harm reduction. Harm reduction brought together everything that meant anything to me. It meant giving people power over themselves and their lives. It meant valuing evidence and science. And it meant making things about more than compliance. In harm reduction, it's about people and their rights and how they deserve to be treated with compassion and care, regardless of the choices that they make. I'm going to tell you a couple stories. First story I want to tell you is about a man named Cleo. I mentioned before, I worked in a methadone clinic. And while there was a patient there named Cleo. Cleo was, not that we had favorites because we were professionals. Cleo would have been our favorite. He was kind, he was gentle, he was punctual. He was just a wonderful man. Cleo had been stable in his methadone treatment for a very long time. The thing to know about Cleo is Cleo came of age in the 1950s and 60s in small-town Texas, and he was brutally and repeatedly raped by a man who lived near him. Now, as you can imagine back then, rape was not necessarily a common topic, and certainly not something that was talked about happening to males. Cleo had no idea this was something that could happen to a male. So he internalized this, and he told no one. So the brutality continued for years until he became big enough and strong enough to fight the man off. Well, by that time, the damage had long been done. Understandably, Cleo had PTSD and he had anxiety, but at the time, he didn't really have the words for that. But Cleo found relief in heroin. When he used heroin, he could feel safe and he could relax. Cleo was a complex fellow, and so around the time he was discovering heroin, he was also discovering college and doing quite well. So his life continued on these two parallel tracks. On one, he had a successful career, wife, and a young daughter he adored. And on the other track was his increasingly chaotic life with heroin. And these two parallel tracks continued until they became perpendicular. And Cleo had to choose. And he chose his career and his wife and his daughter. And so in doing so, he stopped heroin. He enrolled in the methadone clinic. He got a wonderful psychiatrist. He had years and years and years of trauma therapy. He got on medications. By the time I met him, he had been stable for close to 15 years. And he was kind and successful and all the things. And we always told him how wonderful, how resilient, how amazing he was. So imagine how surprised we were when we found out that Cleo violently ended his own life. What did we miss? What did we miss? We went through dosing records and treatment plans and med callbacks and all the things trying to figure out what it was we missed. We even saw the autopsy results. Nothing was in there that wasn't supposed to be there. No amounts were off. What did we miss? It would bug me for years. It would stay with me. What did we miss? And one day I was driving down the street and it hit me what it was I missed. And what I missed was the whole effing point. I was so blinded by Cleo's compliance that I failed to see his suffering. I failed to see that in giving up heroin, he gave up that feeling of safety, that feeling of relief. All we ever saw was what he gained, and we never validated and honored what he gave up. Now, I don't hold myself accountable to that man's death. I do hold myself accountable for not seeing him and his pain and his struggle more clearly when he was sitting in front of me. Never again will I see abstinence or compliance as the marker of anything other than the absence of drugs. Cleo's story is kind of the risk of what happens when we take such a narrow view of success and treatment. Fortunately, it doesn't have to be that way. I want to tell you the story about Shane. Shane came to see me. Shane had recently quit cocaine. He was like, I'm done with cocaine. But alcohol was still in his life. And the people in his life were like, you need abstinence. Shane was like, I'm not so sure. Shane also kind of was stuck in this kind of idea that there was these two binary constructs, these two choices that he's stuck with, right? He can either continue drinking exactly the way he is, or he can abstain. And so when he came to see me, he felt really conflicted, right? Like, I don't know. And he said, I'm worried if I choose abstinence, because that's what everyone around me wants, I'm going to resent them. And I'm going to be miserable. So I was like, well, Shane, let's talk about your choices. Because you don't have just two. You actually have four. I got out a piece of paper and I drew a diagram for Shane talking about safety, control, moderation, and abstinence. And Shane kind of looked at me and he was like, what? I was like, I know, right? This is pretty cool work. So we have safety. Safety encompasses things like not drinking and driving, using clean needles if someone's injecting heroin, having Narcan in instances of overdose. Then we have control. Control is a little confusing for people. There's a couple ways to think of it. One, we could think of it as sort of meaningful rules that a person can kind of box themselves into. But control also is about incorporating rituals and sanctions that are relevant to a person, right? So that has to do with deciding when they might want to use or drink, or where, or with whom, and under what circumstances. Some examples of control might be someone deciding, I am no longer going to drink in any part of my work day or around my colleagues. Or I'm not going to use any substances when my kids are home and I'm in charge of them. Or I am not ever going to use when I am in a state of extreme anger, because I tend to have worse outcomes. All of those are examples of control. And ideally, anything in control is very individualized and specific to what makes sense to a person. Then we have moderation. Moderation entails a person knowing how much they're using or drinking and then lowering their use to a level that allows them to feel better about themselves, and by extension, reduces harm. Moderation works brilliantly for people who like the specificity, who like exact rules, exact numbers. But for people for whom moderation feels a little too rulesy, I'll kind of guide them a little bit more to control. And then we have abstinence. So abstinence could include total abstinence, but abstinence could also include abstaining from one substance, but not another. So a person may decide, you know what, marijuana is really not a good fit for me in my life. I want to abstain from marijuana, but I actually feel okay about doing cocaine once in a while, so I'm going to keep the cocaine use. And in harm reduction, we would accept that as a goal. So I presented these options to Shane and gave different examples, and interestingly, he kind of ended up drawing pieces from each. With regards to safety, he was still drinking and driving at times, despite intellectually, logically knowing that that wasn't a good idea. He understood that, but he also kind of had this idea of, I know when I've had enough and I shouldn't drive. And I was like, well, except you don't, right? Because how drunk we feel and what our blood alcohol concentrations say, not always the same. So I actually encouraged Shane, get a little breathalyzer just for information purposes. Drink what you're going to drink, blow into it, and see what happens. And he was like, oh, drunker than I realized sometimes. So that for him really helped close the door on him drinking and driving, a key component for safety. Also, Shane had already stopped doing cocaine when he came to see me, and that was a strength that we built on. With regards to control, he decided that midday lunch drinking, which he just kind of did out of habit, realized wasn't really serving him. And so he decided that he wanted to eliminate that. That just didn't feel helpful to him. Moderation, he decided that there were certain circumstances in which he wanted to moderate, and he wanted to sustain abstinence when it came to cocaine. Shane feels more empowered. He feels more hopeful, and he feels almost kind of like invigorated, like, wow, like I'm able to make these changes. Like these changes are my ideas. These are my goals. And he sees himself making these positive shifts, and he really wants to sustain them. And some of that motivation comes from it being from within him. That's his idea. I just give the information. Here's the thing. In an abstinence-only modality, none of what Shane accomplished would have been considered any kind of success. In fact, Shane might be considered a failure, which is a little crazy because Shane stopped endangering himself and others by drinking and driving. He decided on his own that removing cocaine was an important part of his overall health and wellness. He removed kind of that midday drinking. He made a lot of important changes that for him were success, and that's huge. I don't know about you, but in my graduate school program, I had one drugs class, and that one class apparently told me everything I needed to know about drugs and addiction, and I think we barely touched on harm reduction. That's just not enough. That's not enough information to support this population. So I was so grateful to have the opportunity to partner with Therapy Wisdom and to develop this course integrating harm reduction into the clinical practice. This course begins with asking, what is addiction? It's a great big question, and it's worth asking for clinicians. Because in order to work with addiction, we have to start stepping back and looking at some of our own beliefs. And then we get to module 2. In module 2, we're deepening our view of addiction. Kind of an overlying theme of module 2 is this idea that addiction is a human problem. There's this misconception that addiction is all about the drug, or it's all about the substance. In reality, most people who try drugs, even repeatedly, do not become addicted to them. The highest rate of dependence after experimentation of any drug is tobacco at roughly 32%. Heroin, cocaine, alcohol all rank significantly lower than that. Now, those numbers aren't negligible, but they're not the majority. They're not even half. So what that means is that addiction is not about the drug nearly as much as the human experience, which makes sense, and it's good news for you. Because what that means is that all of the factors that are coming together to create this kind of foundation for addiction to take root are the exact things that you probably already have experience in working with. Pain, shame, trauma, suffering, disconnection. That is where so much of the best and most meaningful work starts to take root in this process. Module 3 is bringing harm reduction into your office. Module 3 is where we really delve into the details and the nuance of the 4 ways to change: the safety, control, moderation, and abstinence. We also talk about and debunk some key myths around addiction, things like the need to hit rock bottom, or the idea that people fail if they have any kind of lapse. And then we get to Module 4, deepening harm reduction therapy. Very often in addiction work, or even just substance use work, it feels like there's a mismatch, right? We are having some kind of concern about what a client's experiencing or what kind of choices they're making. And yet, it looks like they're not really motivated, or it looks like they're not really concerned. So one of the things we cover in great detail is the idea of the stages of change. The heart of harm reduction is meeting people where they are. Honestly, it's easier to do that when we understand where they are. And so for that, the stages of change model is really brilliant. And we'll wrap it up with coming up with ways to help our clients sustain the changes that they've worked so hard with you to make. And finally, we end with Module 5, maintaining connection and working with addiction. As I've said, I love this work and I love this population. But let's face it, once we throw drugs and alcohol into things, sometimes things get a little weird. It's just the nature of the work, and it's fun, but sometimes that weirdness, sometimes that intensity, sometimes that stuff makes it a little hard on us. So in this module, we talk about some common traps to avoid in addiction work. And most importantly, we talk about ways to take care of you. Our clients struggling with addictions, they need you. They need you so badly. But that also means that they need you to be okay. And so we're going to talk about compassion fatigue and hopelessness and combating clinician burnout. Because we need you to feel strong and to feel good in order to do this work. And this is not easy work to do, but it's so, so rewarding. And I truly hope that you love it as much as I do. When I hear people describe addiction or describe what it would be like to work with addiction, I hear words like scary, frustrating, frightening, overwhelming. What I love about this harm reduction work is in working in this way, I so rarely feel frustrated. I so rarely feel overwhelmed. And I so rarely feel frightened. Not to say that it never happens, but when it does, it's like, that's different. I need to pay attention to it. When we can kind of settle in with our clients and we can let go of that judgment and let go of that fear, let go of that societal expectation that the only thing that matters is abstinence, it's free, it's light, and it allows us to really meaningfully connect with clients and be a guide, be a co-pilot in the process, rather than feeling responsible for one particular outcome. I so love this work, and I love harm reduction, and I'm so excited to be able to share this with you. Because as much as I believe and love advocating for my clients, I really love making this work feel fun and tangible to the clinicians who are supporting clients in communities all across the country. Our clients struggling with addiction need support, and they need you. I'm so grateful to have you join me on this journey to work towards strengthening our work and supporting our clients along the way.